Welcome to this presentation on valvular heart disease. As you can see from the ECG tracing here, the heart's electrical activity is complex, and when valves malfunction, it can have significant consequences. Today we'll be diving into the specifics of these conditions. Let's start with a quick overview of heart valves. These leaflets of tissue are crucial for ensuring blood flows in one direction through the heart. Injury or damage can disrupt this flow, leading to a range of dysfunctions. Remember, echocardiography is the gold standard for diagnosing valve disorders. Here's a labeled diagram of the heart, highlighting the key valves we'll be discussing: the pulmonary, tricuspid, mitral, and aortic valves. Understanding the location and function of each valve is essential for grasping the pathophysiology of valvular heart disease. Valve disorders can lead to several complications. Patients are at an increased risk of clot formation, potentially requiring anticoagulants. Also, damaged valves can become a site for infection, sometimes necessitating prophylactic antibiotics. Depending on the severity, surgical repair or replacement may be necessary. Now, let's talk about the causes of valvular heart disease. Rheumatic fever, stemming from a streptococcal infection, is a major culprit, although its incidence has decreased in the US due to antibiotic use. Other causes include congenital issues, MI, trauma, infection, inflammatory conditions, arteriosclerosis, and aging. A quick review of heart valve anatomy. The atrioventricular valves, the tricuspid and mitral, control flow between the atria and ventricles. The semilunar valves, the pulmonary and aortic, regulate flow out of the ventricles. Remember the importance of the chordae tendineae and papillary muscles in AV valve function. This image provides a more detailed look at the heart's anatomy, including a close-up of the mitral valve. Notice the chordae tendineae and papillary muscles, which are crucial for preventing valve prolapse during ventricular contraction. Let's discuss heart sounds. S1, the first heart sound, is produced by the closure of the mitral and tricuspid valves. This marks the beginning of systole, when the ventricles contract and eject blood. S2, the second heart sound, is caused by the closure of the pulmonic and aortic valves. This signals the end of systole and the beginning of diastole, when the ventricles relax and fill with blood. S3 and S4 are additional heart sounds that can indicate underlying pathology. S3, often normal in children, can suggest heart failure in adults. S4 is usually abnormal and associated with conditions like hypertension and left ventricular hypertrophy. Heart murmurs are sounds transmitted through the chest wall due to turbulent blood flow. They can be physiologic, often innocent and related to high blood flow states, or pathologic, caused by valve deformity or dysfunction. Pathologic murmurs may require medical intervention. Patients with valve dysfunction may experience a range of symptoms. These can include dyspnea, excessive fatigue, exercise intolerance, and syncope, especially with physical exertion. In more severe cases, palpitations and heart failure symptoms may develop. Valve dysfunction primarily manifests as either stenosis or regurgitation. Stenosis is a narrowing of the valve opening, increasing resistance to blood flow. Regurgitation is a leaky valve, allowing blood to flow backward. The consequences of valve dysfunction can be significant. Dysrhythmias can occur due to overstretching of heart chambers. Turbulent blood flow increases the risk of thrombus formation, potentially leading to stroke, MI, and heart failure. Echocardiography is the primary diagnostic tool for evaluating valve disorders. Different types of echocardiography, including TTE and TEE, provide detailed images of the heart and valves. Annual echocardiograms may be necessary for patients with known valve disorders. Medications play a crucial role in managing valvular heart disease. Nitrates can reduce ischemic chest pain. Beta blockers decrease heart rate and peripheral resistance. Anticoagulants reduce clot risk. Diuretics reduce blood volume overload. And antibiotics may be needed prophylactically. When medications are not enough, surgery may be necessary. Options include valvotomy, valvuloplasty, and valve replacement. Valve replacement can involve bioprosthetic or mechanical valves, each with its own advantages and disadvantages. Surgery can be performed via open heart or invasive percutaneous approaches. Mitral and aortic stenosis are the most common valve disorders. Calcific aortic sclerosis is the most prevalent valve disorder overall, particularly in older adults. Mitral stenosis typically develops due to rheumatic fever. Rheumatic heart disease often manifests around age 30 to 40. Mitral annular calcification, MAC, is associated with aging and atherosclerosis. Mitral stenosis impedes blood flow from the left atrium into the left ventricle, resulting in a characteristic murmur. This diagram illustrates the pathophysiology of mitral stenosis. The narrowed valve restricts blood flow into the left ventricle, causing blood to back up into the left atrium. This leads to left atrial enlargement and increased hydrostatic pressure in the pulmonary veins, resulting in pulmonary edema. Mitral stenosis leads to decreased cardiac output due to reduced blood flow into the left ventricle. The left atrium becomes overloaded, and fluid can back up into the lungs, causing pulmonary edema. This increases the risk of atrial fibrillation and stroke. Patients may experience dyspnea with exertion, paroxysmal nocturnal dyspnea, and orthopnea. Mitral insufficiency, also known as mitral regurgitation, occurs when the mitral valve doesn't close properly. This causes a portion of blood to move from the left ventricle back into the left atrium. It can decrease blood flow for coronary circulation and may occur post-MI due to papillary muscle damage. Often asymptomatic post-MI cases should be assessed with echocardiography. This diagram illustrates mitral insufficiency. The loose mitral valve allows backflow of blood into the left atrium during ventricular contraction, resulting in decreased aortic blood flow. Causes of mitral insufficiency include mitral valve prolapse, rheumatic heart disease, infective endocarditis, certain drugs, myxomatous degeneration, mitral annular calcifications, and Marfan's and Ehlers-Danlos syndromes. Marfan syndrome, as shown here, is characterized by specific physical features. Clinical signs and symptoms of mitral insufficiency can range from being asymptomatic to severe symptoms like chest pain due to decreased coronary flow and exercise intolerance. Pulmonary symptoms may arise due to fluid backup in the lungs, and atrial fibrillation can occur. A diminished S1 sound may be present. Treatment for mitral insufficiency includes medications such as ACE inhibitors, angiotensin receptor blockers, ARBs, beta blockers, and diuretics. Surgical options include repair rather than prosthetic replacement. A mitral clip can be implanted to mechanically close mitral valve leaflets. Mitral annular calcification, MAC, involves calcium deposits developing in the rim of the mitral valve. This may cause mitral stenosis or insufficiency. It's usually asymptomatic, and surgery is only performed in severe cases. Mitral valve prolapse, MVP, is relatively common in females aged 14 to 30 years. It's often asymptomatic with an unknown cause. Myxomatous degeneration of the valve tissues causes poor closure as leaflets prolapse upward into the left atrium. A murmur is often present. This diagram illustrates mitral valve prolapse. During left ventricular contraction, weak mitral valve leaflets allow blood leakage into the left atrium. Most MVP cases do not require treatment. MVP syndrome includes benign MVP with sporadic episodes of leaflet prolapse and symptoms like dizziness, palpitations, atypical chest pain, and anxiety. In severe cases, typical mitral insufficiency signs, symptoms, diagnosis, and treatment are necessary. Endocarditis prophylaxis is not recommended for patients with MVP. Aortic stenosis is the most common valve disorder in the elderly. Causes include aortic sclerosis, calcification of the aortic valve in the elderly, rheumatic heart disease, and congenital valve defects. The increased resistance makes it difficult for the left ventricle to eject blood, leading to left ventricular hypertrophy, LVH. Signs and symptoms of aortic stenosis include exertional dyspnea, pulmonary edema, angina pectoris, and a murmur. Treatments include valve replacement and bisphosphonates. Hypertrophic cardiomyopathy, HCM, involves enlargement of the interventricular septum of the left ventricle. This inhibits ejection of left ventricular blood. It's a genetic disorder. An enlarged LV compromises functioning of aortic and mitral valves, and a murmur is present. These diagrams illustrate the difference between a normal heart and one with hypertrophic cardiomyopathy. Note the thickened ventricular septum and narrowed outflow tract in HCM. HCM increases the risk for both atrial and ventricular dysrhythmias and can cause sudden death, especially due to ventricular dysrhythmias. Diagnosis is made with echocardiography. Treatments include avoiding strenuous exercise, beta blockers and calcium channel blockers, surgical removal of excess tissue, LV myomectomy, percutaneous transluminal septal myocardial ablation, and valve replacement and pacemaker. Aortic insufficiency occurs when a deformed aortic valve does not close properly, leading to backflow of blood from the aorta into the left ventricle. This causes dilation and decreased contraction of the LV and backup of blood into the pulmonary circulation. Causes include rheumatic heart disease, endocarditis, aortic dissection, Marfan syndrome, and chronic HTN. A murmur is present. This diagram illustrates aortic insufficiency. The weakened aortic valve fails to close tightly, causing backflow of blood into the left ventricle. In severe cases of aortic insufficiency, a murmur may be present, and backflow affects the mitral valve. The LV impulse is often visible through the chest wall, displaced laterally and inferiorly. A diastolic thrill may be present. Diagnosis is made with echocardiography, and treatment involves aortic valve replacement. Pulmonic valve disorders are not common. They may be due to pulmonary hypertension or congenital heart disease. Pulmonic stenosis involves narrowing of the valve, increasing the workload on the right ventricle, which may cause RV failure. A murmur is present. Treatment involves percutaneous balloon valvotomy. Pulmonic insufficiency occurs when the valve does not close properly, leading to overload of the right ventricle and signs of right side heart failure. It's commonly secondary to pulmonary hypertension, but other causes include congenital heart disease, rheumatic heart disease, and endocarditis. A murmur is also a sign. The treatment is valve replacement. Tricuspid valve disorders are the least common valve disorders. Tricuspid stenosis prevents blood from entering the right ventricle as expected, and a murmur is present. Causes of tricuspid stenosis include rheumatic heart disease or infective endocarditis, IE. IV drug use may lead to IE. The treatment is valve repair or replacement. Tricuspid insufficiency can be caused by RV infarction, rheumatic heart disease, IE, and pulmonary HTN. Ebstein's anomaly is a congenital defect in which the tricuspid valve leaflets are positioned further down in the RV, creating a small RV chamber. Signs of RV failure include a murmur. Treatment includes addressing any IE and pulmonary issues. Thank you for watching. We hope this presentation has been helpful in understanding valvular heart disease. Please subscribe, like, and share for more videos.